Presentation regarding diagnosis of rare cardiomyopathy by echocardiogram. I'm requesting Dr. Heru Amin.
Honorable teacher and dear audience, Assalamu alaikum. Welcome to all to my presentation. I am Dr. Muhammad Heru Amin from NICBD, going to present my case, echocardiographic diagnosis of rare cardiomyopathy. Today I am going to present two cases. In my first case, a 35 years old female presented with palpitation and syncope to our emergency department. Patient gave no history of any hypertension, diabetic or ischemic heart disease. ECG inside and outside hospital show different conduction block in the form of 2:1 AV block and sometimes complete heart block. Echocardiography in parasternal long axis view showing the basal part of anterior septum is thin and akinetic. There is also feature of pericardial effusion is present. In parasternal short axis view at the level of the papillary muscle showing the anterior segment, anterior septum and anterolateral segment is thin and akinetic. There is also evidence of pericardial effusion is present. In apical four-chamber view, there is a thinning of the basal part of the inferior septum, and there is evidence of mitral regurgitation mild. And one LV function study, the Bipin method LV function about 44%, that is impaired, and diastolic function is also impaired. But RV function is intact, and global longitudinal strain about minus 7.5. So on the basis of patient history, ECG change, and echocardiography, we suspected the conduction abnormality most likely due to coronary artery disease. So we do the coronary angiogram, but coronary angiogram reveals no abnormality. As the patient has conduction abnormality in the form of complete heart block with syncope, so we do dual chamber permanent pacemaker of this patient. And during the causology analysis, we try to find out the cause, and we found that the patient's CRP was high, and serum calcium was high, and serum SC was high. So based upon these three investigations, we think there may be one possibility of conduction abnormality may be related to sarcoidosis. So what we do chest X-ray of that patient, but chest X-ray show there is no lung involvement. So during the literature review, we found that in patient with sarcoidosis, there may be thinning of the basal septum occurs in 4% patient. And there may be regional wall motion abnormality, non-coronary distribution can be occurs in 51% patient. There may be pericardial effusion present and sometimes mitral regurgitation moderate present in 11% patient. In our patient, there is typical thinning of the basal septum with akinesia occurs, and there is also mitral regurgitation present, and also non-coronary distribution of the regional wall motion abnormality present, as well as there is pericardial effusion is present. So on the basis of this finding, we think there may be possibility of sarcoidosis. So what we do the cardiac MRI of this patient, and cardiac MRI reveals there is a red gadolinium enhancement along the distribution of our echocardiographic changes. So we confirm our diagnosis as a case of sarcoidosis. So whether this is a case of isolated cardiac sarcoidosis or due to as a part of cardiac involvement in sarcoidosis, we do the PET scan of this patient, and the PET scan reveals there is one cardiac involvement, no other side 5-fluorodeoxyglucose uptake occurs. So according to Japanese Circulation Society guideline, the major criteria of cardiac involvement, we confirm our case as a cardiomyopathy due to isolated cardiac sarcoidosis. So in my second case, a 18 years old boy presented with shortness of breath in our outpatient department. Previously, he was diagnosed as a case of dilated cardiomyopathy with heart failure. The ECG of that boy reveals there is a T inversion in 2-3 AVF and from V1 to V5. So in echocardiography, in parasternal long axis view showing both LV and RVOT diameter is increased, and there is global hypokinesia of the LV. And RVOT proximal diameter about 38 millimeter. And in parasternal short axis view at the level of the great vessels, there is akinesia of the RV anterior wall, and RV proximal diameter is about 40 millimeter. And also there is LV is dilated, LV ventricular end-diastolic diameter about 61 millimeter. And in apical four-chamber view, there is free wall of the RV is akinetic. There is apical RV aneurysm is present. And there is also thick moderator band is present. So there is a RV aneurysm in the free wall. And RV is dilated, there is tricuspid regurgitation is present. And there is RV systolic dysfunction is also present. And one LV study, there is a severe LV systolic dysfunction, about ejection fraction is 20%. So based upon our echocardiography finding, we think this is a case of arrhythmogenic right ventricular dysplasia with LV involvement. So according to Padura diagnostic criteria, 2020 international criteria, as the patient has also RV involvement and LV involvement, our diagnosis is a case of biventricular arrhythmogenic cardiomyopathy. So we confirm this again with cardiac MRI, and cardiac MRI reveals both RV and LV is dilated with thinning occurs. And there is a feature of both biventricular cardiomyopathy. So our final diagnosis, this is a case of biventricular arrhythmogenic cardiomyopathy. So my take-home message is, though detection of rare cardiomyopathy, including cardiomyopathy due to sarcoidosis and biventricular arrhythmogenic cardiomyopathy, are challenging, supervised and dedicated echocardiography can overcome these challenges. So thank you all.
Thank you, Dr. Heru, for your beautiful presentation.